who've gotten better with therapy, enough so that they don't have surgery for the cyst. And so you can't assume, so thank you for pointing that out, because we do have the primary muscle tension dysphonia patients, but you also have muscle tension that goes along with pretty much every other voice disorder to some extent. Even some neuro voice disorders, you might be able to reset and reposture, and just know that in some of them, like spasmodic dysphonia, for example, they'll initially respond to this, but it's a gest antagonist. It's like a short-lived sensory trick, and then it will get better. Okay, great. So, so you want to see the longevity of these techniques. Other questions? We have 3 minutes. Mm-hmm.
I was just curious how, if a person has been aphonic for an extended period of time, years and years, does that change the way you habituate it or anything in the process?
No, actually, do you know what? I've had some of the most severely disordered voices and had them for like 4 years and fixed them in single visit. Yeah. It doesn't seem to be related. It's not linear. And you would think it would be, right? I would think that. But
sometimes they're so up and tight that there is no gap.
right.
Yeah.
So
Might
you
have
have
to
a
palpate and massage a little bit first to kind of open it, and then, but even if this is like no space, I'll still push and try to reset and get a better voice. It's a great question.
With these functional patients, do you use laryngeal reposturing first, or do you try other techniques first?
I usually try this first unless I have a specific diagnosis like Parkinson's, or I suspect Parky, I might like have them get loud first or something. But this I always use before I do imaging.
So you do this first before you do imaging?
Yeah. Because a lot of times I want to see, like, if they're functional, they have a really bad voice, you're not going to see anything on your imaging if they're like clamping down, you know, super glottally. It's pointless. And, you know, so I'd rather see their function after I've really stimulated the tension.
Well, I think about the same thing she asked about when it's so much tension. If you give some massage, sometimes if it's too severe for them to practice at home, thinking that you might see him or her once or twice a week, and that might not be like enough. Do you do that, like giving the direction for them?
Yes,
to
I
do
will give
massage?
them that exact handout. And you guys are welcome to make copies or whatever. You can, I borrowed this, I reformatted this from Julia Ellerson, who was at Bob Saddleup's office before we stole her in Utah. So you're welcome to steal it and give it to people.
And the other thing I was thinking, because you mix a lot of methods together, how do you manage?
1 minute.
How can you know like the effectiveness of these specific technique, thinking that you are mixing a lot?
Good question. You know, it's a really honest question because you can't do this without doing something else with it. So in truth, even the literature that's been published, even in Dr. Roy's literature, it publishes on manual circumlaryngeal techniques, but he was using increased loudness, he was using semi-occlusion. Yeah, for sure. Yeah. So I think it's probably not an isolation technique because you have to phonate, and when you're phonating, you're doing something. So, okay.
Is there anyone who's never do